And that's a perfect introductory remark, because I think many people have no knowledge that stroke in the newborn is as common as stroke in the elderly. Now, stroke in childhood is a little bit less, and we'll go over those numbers. Just for a show of hands, how many of you in the audience have seen a child with a stroke? Okay, great. So maybe by the end of the lecture, everybody will feel comfortable in diagnosing this condition. So just a minute on definition. So we use the term perinatal stroke for stroke that occurs at or near the time of birth, neonatal stroke from in utero all the way through the first month of life at the end of the neonatal period. And then from that time to 18 years, we call it childhood stroke. And as somebody said yesterday, the child is getting older and older over time, so maybe this will expand. And then we have young adult and older adult stroke. But we're going to focus on primarily neonatal stroke and then some stroke conditions in children. So this is data from the International Pediatric Stroke Study Group. This is an organization that was founded by Gabrielle de Weber at the Hospital for Sick Kids in Toronto, and it now involves over 80 countries. I do believe we have enrollment from India as well. And you can see here that a third of the stroke patients are newborns. This is just age-adjusted rates for stroke in children, and if you look across between AIS is arterial ischemic stroke, HS is hemorrhagic stroke. And if you look across different countries, you'll see similar incidences for both, with cumulative rates at the bottom, with total rates, oops, sorry, this is going to be tricky. Total rates running about 1 in 20,000. So for neonatal stroke, we have 1 stroke per 4,000 live births. That's where we get the numbers from, basically kids who are presenting. So it's really, again, a condition of tip of the iceberg, because not all neonates will present in the newborn period with a stroke, and we'll talk about that delayed presentation. Neonates, in addition to having arterial ischemic stroke, will have sinovenous thrombosis as well, and you have to remember that greater than 50% of all childhood sinovenous thrombotic disease occurs in the neonatal period and can be associated with a number of findings like congenital heart disease, extracorporeal membrane oxygenation, thrombophilias, and chorioamnionitis. Here's a condition that you won't see at term, but you'll recognize later when the patient comes back, brought by the family because they're not using a limb. And so no clinically apparent perinatal difficulties, but then when we scan them, we see this curious finding of white matter injury that looks like a little bit like PVL, but it's a venous infarction, and you can see it's long-standing because there's Wallerian degeneration in the cerebral peduncle. Hemorrhagic stroke also occurs in the newborn, but is very rare, and they'll always present with encephalopathy, and most will have seizures. We don't really know the causes of this condition, but one thing we do know is that there are risk factors for this, and here again is modifiable risk factors. So if you look carefully here, post-maturity has a 7-fold increase in odds for perinatal hemorrhagic stroke. So something that's conceivably preventable. Preterm babies have stroke as well, and we often don't think of the preterm infant as having a stroke, but they do have strokes, and they have strokes that are very recognizable in their location. Their incidence is about 7 per 1,000 live births. It can occur at any time postnatally, more common on the left, just like in the neonate and the young child. But it's the deep structures that are actually showing the lesions, the lenticulostriate. And Dr. DeVries, in this wonderful paper by Manon Benders, showed that there is some risks like abnormal fetal heart rate, twin-twin transfusion, and hypoglycemia. And this is what it looks like. So instead of the big middle cerebral artery infarct, you're actually seeing an infarct in the lenticulostriate distribution involving thalamus or the caudate or putamen. So for clinical presentation, those are the ones we've recognized. That's where the number 1 in 4,000 comes from. These kids will present with seizures. What kind of seizures? Always focal tonic seizures. When you see an infant who is just shaking their right arm and it's a seizure, you must do an imaging study to rule out a stroke. So this was a baby who looked apparently well, born at term, normal delivery, APGAR is good, but developed seizures at 8, focal motor seizures at 8 hours of life. And look at that huge MCA distribution lesion seen on the CT here. Now, delayed presentation is the harder one to pick up, and this is adding to the numbers, but we're not picking them all up. These are the kids who are called cerebral palsy. They come in with pathological handedness at a very early age. The parents will bring the baby in and say, my baby's not using their left arm, for example. And here's my patient with a very large MCA stroke. And this is what he looks like. And so he looks like a normal, healthy, happy boy, but the astute clinician will notice something here. Importantly, he's not looking at the camera. He has a gaze preference. So that tells us he has a homonymous hemianopsia. He's obviously fisting with that left hand, and he has paucity of movement on that left side. So this is a baby who has a left hemiparesis and the scan that I showed you. So delay presentation can be arterial or venous. With the arterial disease, we're more likely to see seizures and non-motor delay, and some history of acute perinatal factors if you dig for them. Whereas with periventricular venous infarction, that little white matter abnormality I showed you just a few slides ago, a very long time to make the diagnosis. And these are the kids who are more likely to have isolated motor findings, not cognitive abnormalities. And thrombophilias seem to be the same in both groups and are often normal despite extensive testing. How do we evaluate children with perinatal or neonatal stroke? We always do an MRI. We try to get an MR angiogram or venogram, especially if we're concerned about venous thrombosis. And EEG is always part of the workup because you get more information, not just seizure activity, but brain function as well, obviously. We don't often do echocardiograms, only if we see something on exam. We do metabolic workup because congenital disorders of glycosylation, which are rare, can present with stroke. Some organic acidemias lack congenital lactic acidoses. But it's important to work up both the mother and child. This is a disorder of the maternal fetal unit and can be thrombophilia. So you should wait, because if you want to measure some of the coagulation factors, you're not going to pick it up at the time of the stroke because they're going to be consumed. So you might get a falsely deficient abnormality. So genetic tests can be done in the nursery, but you should make sure you do the parents as well. Treatment of neonatal stroke I can cover in one slide because we don't really know what to do with this. And when we look at the data from the International Pediatric stroke study, you can see that the majority of the neonates here with whether it's arterial ischemic or cerebral sinovenous thrombosis. So here's AIS is in blue, yellow is the venous disease, and some of them actually have both. Most of these kids are not being treated. And we'll go over the ASA guidelines and talk about classes of evidence in a few minutes. What are the risk factors for neonatal stroke, and are any of them modifiable? So in a very large study done by Yvonne Wu at UCSF from the Kaiser Permanente Health Maintenance Organization, she found a number of different odds in the mother that increased the risk, and those included a history of infertility, oligohydramnios, preeclampsia, PROM, and abnormalities like chorioamnionitis. So maternal risk factors important. During labor, prolonged second stage, any fetal heart rate abnormality, emergency C-section, and somebody brought up C-section yesterday, birth asphyxia and resuscitation all seem to be risk factors in univariate analysis. So when we're faced with this duality of risk, what do? We look for, try to look at the placenta, which in our hospital, as advanced as it is, very hard to get the placenta and actually look at it. But we encourage you to look for chorioamnionitis. We do work up for thrombophilias, but for the most part don't see them that often. We do metabolic workups. We make sure congenital heart disease is not in the diagnosis, and of course, rule out infection or any trauma. From the International Pediatric Stroke Study, we looked at all of our data, and we found in this large study that moms and their pregnancies appeared healthy. So there was no way to pick up from the pregnancy itself whether that mom was at risk, except if you kept in the back of your mind that the mom had a history of infertility. The neonates often required resuscitation, and some of them had systemic illness. And I know for many people, we think of newborns with stroke as being well babies who present with focal seizures. But about a quarter of them are not well and actually are pretty sick. And some of them did have cardiac and prothrombotic abnormalities. I showed you this yesterday. Risk factors for congenital hemiplegia can be determined on an MR scan. And the good news is that you can tell a family if there is an MCA infarct. If you don't see this signal, that child will likely be normal. That's great news that you can give the parents right at the very beginning, right at the onset. But if you do see corticospinal tract diffusion abnormalities, you're concerned about motor disability, and please involve the physios early. We at UCSF also looked for risk factors. We looked at a number of polymorphisms in the usual suspects for adult stroke, genes that regulate thrombosis, thrombolysis, cytokines, and vascular tone. We had 59 newborns with stroke, and we matched them to 347 controls and found no significant difference. And I think this, in part, is a population problem. You need large population studies to pick up some of these factors. In a meta-analysis of thrombotic factors, both factor 5 and factor 2 seem to come up a little bit more than anything else in a number of these studies. So they should still be in your mind, and testing should be done. And here's a very interesting gene. This is probably the one gene we know that causes stroke, not just in the newborn period, not just in the preterm period, but throughout childhood and in adults. And we need to look for this gene in adults as well, especially when there's hemorrhagic stroke. Doug Gould described this in a mouse and saw that heterozygotes that lived had poor encephaly. This gene causes a mutation in collagen secretion into the basement membrane and causes structural deficits in that vascular basement membrane. Linda DeVries nicely reported a case of siblings who had perinatal hemorrhage, and here you can see the hemorrhage on the ultrasound, poor encephaly with residual hemorrhage, and this is what the MRI scan looked like. They had mutations in COL4A. But the spectrum is really expanding, and I draw your attention to a beautiful neurological progress that Linda DeVries wrote in the Annals of Neurology this past year. And you can now implicate this gene and its partner gene, COL4A2, anywhere from fetal to a late adulthood. So this needs to rise to the top of the list. As I told you, the mutations cause protein accumulation, disrupting basement membrane, getting vascular abnormalities that not only result in sporadic intracerebral hemorrhage, but recurrent intracerebral hemorrhage. So very important to know about. How about outcomes? The good news is that most of the neonates do not succumb to the insult, but many of them, more than half of them, have cognitive learning disabilities, motor disabilities, and some of them have epilepsy. And in a number of studies, both from Yvonne Wu's Kaiser cohort, Adam Curtin's cohort, and Doris Trautner from UCSD, we can see that the long-term outcomes include hemiplegic cerebral palsy, epilepsy, learning, cognitive language abnormalities, behavioral and psychiatric, some visual. This is a huge societal burden that is basically not attended to. The good news on the flip side is that the recurrence risk for neonatal stroke is essentially zero unless there's an underlying disease like COL4A, like congenital heart disease. The also good news is that cognitive outcomes seem to be better despite these huge lesions, but if the child continues to have seizures, those children will have cognitive abnormalities. So it looks like plasticity plays a role here, but controlling epilepsy is critical and paramount to good outcomes. So I mentioned low recurrence rate for neonatal stroke, but stroke during childhood is much higher at 25 to 30%. And in a recent paper from Gabrielle de Weber's group published last year in Annals of Neurology, when they looked at children with congenital heart disease, they saw that about 30% of them had experienced a stroke recurrence. So this is the population we really have to take care of, especially if they have an existing prothrombotic state in addition to their congenital heart disease. Now let me just spend a minute talking about the American Heart Association consensus statement. So we did this, it was a combined effort of many people listed on this slide. It was published in Stroke back in 2008. These consensus statements were also published in Chest, and you can get the paper online at the Stroke AHA journals and download these guidelines if you are interested. But let's talk about classes and levels of evidence, because this always confuses me, and I just want to reiterate as we go through some of the treatments that we recommend, what we're really basing those treatments on. Class 1 evidence says that the existing evidence that we have for a disorder is probably useful and effective. So we're looking for class 1 evidence. In the slides I'm going to show you coming up, you're not going to see much class 1. Class 2, conflicting evidence and divergence of opinion, especially about procedures and treatments. Class 2A is favorable, Class 2B maybe less likely. And Class 3 says that existing evidence and/or general agreement is that the procedure or treatment is not useful or may even be harmful. So let's take a closer look at this. So for perinatal, here we are with Class 2, no Class 1. Class 2 recommendations. An anticoagulation may be considered in certain situations, and we only anticoagulate those newborns who show propagation of clot. So that means you have to follow them either by Doppler, ultrasound, or MRI. It's obviously reasonable to evacuate a hematoma if the baby has high intracranial pressure, but most of the babies don't because they have an open fontanelle. It's unclear if removing the hematoma actually improves outcome because the numbers are so small. It's also reasonable to give the baby post-discharge folate and B vitamins if homocysteine is abnormal and an MTHFR mutation is present. So let's talk about a couple of other cerebrovascular lesions and see what evidence we have about some of these. So we'll talk about intracerebral hemorrhage. We'll go back to childhood ischemic infarction, venous thrombosis, and subarachnoid hemorrhage. So finally, we have Class 1 recommendations for the older child. So obviously, thorough risk factor evaluation is critical to any workup of any disease. And replacing clotting factors is another obvious treatment, as well as treating vascular anomalies that might have a bleeding potential, like a large arteriovenous malformation. But Class 3 recommendations say for children, a hematoma removal is not usually beneficial. And this is true unless there is massive increases in intracranial pressure, which don't necessitate removal of the hematoma, but actually necessitate an occipital craniectomy. Transfusions are not recommended to prevent hemorrhage due to sickle cell disease, and I'm going to talk a little bit about that. The etiologies for childhood stroke are more risk factors: congenital heart disease, sickle cell, dissection from a number of causes, meningitis, any coagulopathy, and embolism in a neonate, but we've talked about that. So here's an embolic infarction on pathology, large embolic MCA involving both the deep gray and posterior MCA distribution. Many of these emboli are coming from the heart in kids with stroke. Few strokes really need surgical correction. And the million-dollar question is, why do some of these children have strokes when they're embolizing and others don't? This child here actually had an atrial myxoma. She was 14. Class 1 recommendations for embolism include treating congestive heart failure. So these are just common sense management of a sick patient. Early corrective surgery if needed, and removing the atrial myxoma. But if it's a rhabdo, you might want to consider not doing that. Class 2 recommendations: reasonable to use low molecular weight heparin or heparin before you institute warfarin therapy in the setting of continuous emboli that you've documented on your cardiac echo. And you should continue this therapy for a year or two unless the risk is actually removed, like in the case of an atrial myxoma. Sickle cell disease is a whole different category of disease. We see large vessel ischemic strokes, watershed infarctions. Many of children with sickle cell disease have silent infarctions, subarachnoid hemorrhage, intraparenchymal hemorrhage, and venous thrombosis. So it runs the whole gamut of stroke disease. There are class 1 recommendations, which are obvious. Again, treat the patient well, optimize hydration, oxygenation, and blood pressure. Periodic transfusions when there's an abnormal transcutaneous Doppler. Periodic transfusions after you've confirmed a bland infarct, and trying to keep that sickle hemoglobin below 30%, especially if you're going to try to do an angiogram to document disease. Class 2 recommendations include following the patient with transcutaneous Doppler frequently. Hydroxyurea is a good alternative if transfusion is not feasible. Some patients are actually undergoing bone marrow transplant when severe, and any revascularization surgery is really a last resort. Dissection we see, and we're seeing it more commonly in boys than girls. We see it after even very minor trauma. We've had kids who play this drinking game. I say kids, they're usually 18 years old, and they're throwing their shot of whiskey down their gullet and throwing their head back, and they end up with a vertebral dissection. We've seen dissections in cheerleaders and soccer players, and it just speaks to the ability of any spontaneous or traumatic, mild, trivial trauma to cause a dissection, especially if there's underlying problems like homocystinuria. It's hard to diagnose dissection, especially if the patient presents a little bit late. You often have to do a fat-saturated MRI to see it. And in some cases, anticoagulation may prevent embolism, especially when you see a large pseudoaneurysm on the MRI. And here's a picture of this dissection on angiogram. You can see thinning of the vessel here. This is what this looks like, this large clot. And here's the endothelial surface there. And you can see an absence of the MCA on your MRI. The guidelines for dissection are really class 2. Begin with heparin if the child's older and it's bland. It's reasonable to continue them on therapy. At our place, we don't do that. And surgery is rarely considered, only if that pseudoaneurysm is really large and looks like it'll rupture. And a class 3 recommendation is basically against anticoagulation if there's subarachnoid hemorrhage, or if the dissection, instead of it being in the neck, is actually intracranial. Moya is something that we see actually at our hospital more commonly than we would like. We have a large Asian population on the West Coast. Moya, for those of you who don't know, is a Japanese word meaning hazy puff of smoke. Drifting through the air, very magical saying. And actually, that's kind of what it looks like here on the angiogram. It's this sort of puff of smoke, if you will, there. The term refers to the hazy appearance of those collateral vessels. And the risk factors that you should keep in mind are patients who have neurofibromatosis, any patient post-cranial irradiation from therapy for astrocytomas and the like, Down syndrome, and of course, sickle cell disease is probably the #1 cause of moya moya in the non-Japanese population. Again, here's other lovely radiologic pictures of that puff of smoke, the vessels that are attenuated even posteriorly, and all the micro hemorrhages that you would see. These children often, if it's unilateral, do well with extracranial bypass. So the class 1 recommendations are for revascularization. Some indirect procedures work better for children. The indications for surgery are really if there are progressive ischemic disease or inadequate blood flow reserve. Class 2, using transcranial Doppler, but that's going to be insensitive, and you should realize that. And any technique that can measure blood flow accurately could be useful. Some patients are put on aspirin if they're not, especially if they're not surgical candidates, and obviously you would want to minimize pain and anxiety during any procedure for a child. So when to anticoagulate? Again, we're dealing with very limited evidence. It has not been studied well. There is a trial in the United States right now, and I think it does involve some extra North America sites as well to look at anticoagulation in the newborn. There's also a trial to look at TPA for ischemic stroke in babies or children greater than 2 years, but that data is not in yet. So we're stuck with probably yes and probably no. So the probably yes is recurrent embolism, high risk of embolism, dissection if it's not intracranial, any severe hypercoagulable state, and venous sinus thrombosis. This is children now, not neonate. And probably no, thrombocytopenia, bacterial endocarditis, sickle, big infarcts because you don't want to turn a bland infarct into a hemorrhagic one, and obviously a hemorrhagic lesion. So in conclusion, I hope that I've impressed upon you that stroke through childhood is actually common, and stroke in the neonate is as common as stroke in the elderly. Hemorrhage can be caused by many things in children, especially AVMs, tumors, and thrombocytopenia, but we don't really know the cause in the babies for perinatal hemorrhage, except for COL4A1. Causes of infarction can be from the heart, from hemoglobinopathies, or dissection, so we have to think about all of those things in our workup. Treat any kind of risk factor to prevent recurrence, like infection. And there is value of these common treatment options when we're uncertain. The real issue is that we know so little about stroke in children, and that there's so little funding that goes toward this disease in children to study it adequately. And you can't take a big brain and make it into a little brain, because the pathophysiology is absolutely different. So until we can really heavily investigate these disorders, we are stuck primarily with class 2 and 3 level evidence, kind of running by the seat of our pants on this and hoping that we can eventually come up with large-based clinical trials that can help us determine how to treat these children. I just want to acknowledge the International Pediatric Stroke Study for some of the data that I showed you. Gabrielle de Weber, who's the leader of that, Heather Fullerton now as well, and some of their data I showed you along with Yvonne Wu. And Steve Roach, who led the American Heart